Welcome, everyone, to this month's seminar on spirituality, theology, and health. Today, I am delighted to introduce to you Dr. John Petit. Dr. Petit and I have worked together for at least a decade, and he is a co-author of the upcoming third edition of the Handbook of Religion and Health. Dr. Petit got his MD degree at Columbia University and his medical internship at UNC Chapel Hill, right next to us, although we don't usually mention UNC here at Duke very often because it arouses fights. But in any case, he completed a residency in psychiatry at the Massachusetts General Mental Health Center and a fellowship at Peter Bent Brigham Hospital in Boston. So for 45 years, he has been a psychiatrist at the Brigham and Women's Hospital and at the Dana-Farber Cancer Institute, where he is an associate professor of psychiatry at Harvard Medical School. He's published extensively in the areas of psychosocial oncology, addiction, and the clinical interface between spirituality, religion, and psychiatry. He's a Distinguished Life Fellow at the APA, and he received the APA's Oscar Pfister Award and is the past chair of the APA Caucus on Religion, Spirituality, and Psychiatry. So Dr. Petit has been involved in this area for a long time, and we welcome him now to share his experience. John, take it away.
Well, thank you, Harold. I appreciate your gracious invitation and this invitation to join the seminar, and also the presence of all of you on the call, some of whom I recognize. I have an obvious conflict of interest as the lead co-editor of the book we'll be considering. Let me share our screen. So my aims with you today are to review a recently edited volume, Christianity and Psychiatry, and then to consider where we go from here, both in terms of the remaining gaps and in terms of research, clinical, and teaching uses of the book as a resource. Most of you no doubt appreciate there are a number of reasons why faith can be important in psychiatry. Religiousness generally correlates with improved mental health. Many individuals turn to faith rather than to psychiatry when they struggle emotionally. Psychiatric conditions may have spiritual dimensions. Spirituality and religion can be resources for healing, and clinicians' own worldviews can influence their work. And when it comes to Christianity, we know that as a major faith tradition, it emphasizes divine healing and prayer for healing, that many believers spiritualize their emotional struggles, that some churches reinforce mental health stigma.
John?
Yes.
John, your slides are not advancing. I think you have to put it on the slide, the complete slide, the slideshow.
All right. I thought I had, but let's see.
Yep, that's it.
Is that the one you?
That's the one you hit.
Okay.
And that should do it, but for some reason it's not doing it. Can you go up to slideshow? Maybe that will work. And if for any reason this doesn't work, I'll just advance them from here, but let's try.
I'm clicking on slideshow and I'm advancing them here, but you're not seeing the Why Christianity and Psychiatry slide?
No, we're not seeing that. Well, yes, we see that, but it's got the other slides on the left. It's not a full screen.
Oh, I see. Okay. Let me see if there's a way to get out of that I can figure out.
Yeah, that little thing right there, that should do it. But for some reason,
It doesn't do it for you.
it's not doing it here. Although I think you can probably go ahead like this. Can you advance one more, and let's see if it advances.
Yeah,
If it's advancing. Okay, so go ahead and go back, and we can do it from here. This will be fine.
okay. Sorry about that.
It's okay.
So Christianity also offers resources for personal and social transformation. This is a patient of mine who illustrates both the positive and the negative potential impact of Christian interventions directed at her mental struggles. She's a 60-year-old woman with a history of chronic pain, substance misuse, depression. And after her pastor noticed her depression and reprimanded her for not having more faith, she had more suicidal thoughts, had to leave the church, was traumatized by that. In the past, she'd benefited from AA, but she'd felt more at home in a Christian 12-step program, Celebrate Recovery, that some of you may know about. So the aims of this Christianity and Psychiatry book are to help clinicians better understand the particular challenges and resources involved when treating Christians, to help Christian individuals and family members integrate their faith with their understanding of mental disorders and treatments, describe models of collaboration between Christians and faith communities, and offer a scholarly, conceptual, and practical resource for future work. We have 4 co-editors. Steve Moffick is a Jewish psychiatrist in Wisconsin. Ahmed Henker is a Muslim psychiatrist in the UK, and you know Harold. The book has 21 chapters, 303 pages. It costs too much money, but I had nothing to do with that. There are a number of different kinds of contributors. I'm really grateful to my co-editors and also all of these contributors, as well as to Dan Blazer, who wrote the foreword for the book. We try to include a review of literature, attention to theory, and use of case examples. The book is the third in a series published by Springer Nature. The first one, Islamophobia and Psychiatry, with the 3 of us as co-editors, Steve, Ahmed, and I. Anti-Semitism and Psychiatry, similarly with additional co-editors. And then this one as a third book in the trilogy. These started off in some presentations at the APA that we've given together over the past decade about approaching mental health issues from a faith perspective. This is the table of contents. And what I thought I'd like to do is go through the abstracts for each of the chapters briefly, so you'll have a sense of what the content is there. You don't need to read the abstracts. I think they're available online. And then we can talk about what you'd like to think about from here. Sam Fieldman, as both a psychiatrist and a historian, reviews how Christians have understood mental disorders from the early church through the Middle Ages and in centuries since to the modern era, in which the tensions between psychiatry and Christianity have grown. Even early on, the church understood that psychological distress could be a natural phenomenon with a spiritual dimension. And he points out that more recently, in the modern era, there's been a growing acceptance of the role for spiritual and other spiritualities in fostering mental health, despite the legacy of Freud. Jennifer Harris is a psychiatrist at the Brigham with me, who sees outpatients. And in this chapter, she considers explanations for mental health stigma, how particularly fundamentalist churches can reinforce it, where some of the reasons lie for this in psychiatry and in faith. And she offers some recommendations for reducing stigma within church communities, including remembering that Jesus welcomed and reached out to the stigmatized. Christopher Cook is a psychiatrist and theologian in the UK. And he uses several case examples to illustrate the way that psychotic symptoms, for example, hearing from God, possession, and spiritual experience can overlap and how those with psychotic conditions need to be cared for within church communities with sensitivity and respect. In this chapter, Jennifer discusses the role of faith in contributing to, being a manifestation of, for example, in the case of intense guilt, or helping with recovery from mood disorders. And she considers depression in relation to the phenomena of acedia and the dark night of the soul, and the ways that believers can find hope, perspective, and strength in the scriptures when they're struggling with depression. Nadine Nias is a Canadian psychiatrist experienced in treating survivors of trauma. She outlines here an approach based on optimizing parasympathetic tone to enhance emotional regulation, and then integrating the trauma itself, including through the use of the individual's faith. She also discusses common resistances to this approach from more conservative religious individuals, for example, that it's somehow not biblical. Julie, Joshua, and Mia are child psychiatrists who discuss the way that Christian worldview can help shape human development. And then they use two case examples, one of an adolescent who rebels against her Christian parents, and another whose priest referred her for evaluation of seizure-like episodes that led to treatment for PNES, to make suggestions for treating children and adolescents whose faith and emotional issues are intertwined. In this chapter, Joseph Currier and his colleagues at the University of South Alabama used the case of a patient who was severely morally injured by an accident in which a friend died to explore the literature on moral injury, the current treatments, and the role of faith in that process. They give some attention to the double-edged impact of faith in both becoming a resource in forgiveness, for example, and also in unhelpful theological interpretations that can worsen spiritual struggles or struggles with oneself. Len Sperry at Florida Atlantic University devotes this chapter to what he calls sacred moral injury, referring to the misuse within Christian organizations of people's sacred trust, and identifies this as something distinct from the trauma suffered by military personnel, spiritual distress, spiritual injury, and then describes an approach to this based on the dynamics that foster it and the kinds of interventions that need to take place within an institution, as well as the role of mental health professionals in recovery. John Swinton, who is a theologian in Scotland and a former psychiatric nurse, and his colleague here talk about Christianity and disability, critiquing both secular and incomplete Christian views of disability in favor of one that emphasizes being made in the image of God, loved by him, and called to flourishing within communities. Gloria White Hammond is a pediatrician and a pastor. And in this chapter, she offers some examples of how she prays for patients who are expecting miracles in facing serious illness, how she stays with them as they come to accept their diagnosis and prognosis, with a parallel conversation expressing gratitude for the patient, acknowledging their emotions, affirming their faith and hope, committing to stay with them, and appreciating their clinicians. She talks about how she prays with and also talks with them in this process, something that's particularly common in her African-American community. David Hathaway and Michael Dawes are two addiction psychiatrists here in Boston who review the role of spiritual approaches in addiction treatment, including AA and 12-step facilitation and Celebrate Recovery, and the place of all these in the overall treatment of substance use disorders. Eric Klaas is a psychiatrist and a philosopher in the Netherlands who considers the debate over models of integration within psychology and then within psychiatry. He distinguishes among philosophical assumptions, scientific, clinical, and everyday knowledge, and suggests that if we appreciate psychiatry as a normative practice, we can see a number of ways, top down, bottom up, and within each of these levels of understanding, that worldview and professional practice can interact. This is one of the more theoretical chapters in the book, but it does have some clinical relevance. The next chapter by Harold and Michelle Pierce, who's a psychologist, is by far the most evidence-based chapter. Probably no surprise. It reviews the literature on spiritually integrated psychotherapy for various conditions, discussing the relationship between Christianity and positive emotions, and then helpfully describing the kinds of sessions that take place in two forms of manualized Christian integrated CBT. Christian religiously integrated CBT, which has been used extensively in depression, and Christian spiritually integrated cognitive processing therapy being used to treat PTSD. The authors of this chapter outline three models of Christian psychiatric service delivery with which they've had experience. One is a model delivering care to Eastern Orthodox Coptic Church members in New Jersey. Another is a Christian university/community psychiatry outpatient care model in Toronto, Canada, where Alan Fung has worked. And a multi-site inpatient and outpatient Christian mental health care model in Southern California and Washington State, where Tom Okamoto has had experience. And they talk about the practical issues as well as the tension between faith and science in providing state-of-the-art psychiatric care while delivering spiritually congruent mental health care. The authors of this chapter are both bivocational authors. Nancy Kehoe is a Catholic nun and clinical psychologist, and Mary Landell is a psychiatrist and an adolescent and child psychiatrist and an Episcopal priest. They draw from their experiences, including, for example, in a community discussion group of mental health professionals and clergy, from consultations to pastors and pastoral counselors, conferences and courses, and pitching together in times of crisis and tragedy, which can happen when clergy and mental health professionals come forward. This multi-author chapter has to do with the obstacles and opportunities for educating Christians about mental health from the experience of the authors in various settings, teaching in the community, in a seminary, in an evangelical and in an Orthodox church context, including reference to some of the principles and the practical resources that they've found helpful. Amy Hacker Hughes is a prominent psychologist in the UK who discusses the role of his faith and his sense of calling to a career, and also as a wounded healer as a result of his own treatment for bipolar disorder. Susan Packer is a Jewish psychiatrist in New York City who discusses her experience treating Christian patients, drawing on her own faith, and using several examples, two of which relate to same-sex attraction and one to the issue of abortion. And she talks about issues that come up for Pentecostal, Mormon, Jehovah's Witnesses patients that she's seen as well. Steve Moffick, who, as I mentioned, has been a driver for this series of books, reflects in this chapter on the role of faith in his own life and career, his relationships with Christians, his commitment to interfaith and anti-racist activity, and to better understanding the role of faith in the psychiatrist-faith relationship. Hammond Henker gives in this chapter a fascinating account of his own life and experience with Christians and the professional sanctions that he feels tend to constrain him in the UK when he's considering incorporating a patient's faith into their treatment. And then finally, I trace in this chapter my interest in these issues to influences that were part of my growing up in an evangelical home in the South and witnessing major depression in a close family friend who experienced this as a loss of his faith. Also to the mentors I've had in my training and since, and to the questions with which I continue to wrestle regarding my role as a Christian clinician in my patients' spiritual lives. So I think we have some time to talk next about what some of the gaps might be in this range of chapters on this topic, and also what the implications might be for clinical work, for research, for education. I really appreciate your attention, and I'm very interested in your input.
Okay, so the way we're going to work it then is, if you have a question, just go ahead and ask it, raise your hand, and ask your question. This is a tremendous opportunity to have your questions answered from a world-renowned leader in Christian psychiatry. So this is your opportunity. So go ahead and ask whatever questions you want. There may be some hard questions. That's okay. John can handle it. And go ahead and ask your questions. Unmute yourself and ask.
This is Rhonda, and I have a question. Hello, everybody.
Hey, Rhonda.
It's good to be here. I really appreciated the presentation, and I hope to get the book soon. And my question is, for the patient who, in that situation you gave where the patient was reprimanded by her pastor, for that example, she was reprimanded because she did not have as much faith as he thought she should have.
Right.
How do you help a person who doesn't display faith or a level of faith without making them feel like they're not good Christians?
That's a good question. I think in her case, she felt like she had faith that wasn't being recognized by the pastor.
Okay.
And so it was a betrayal of her sense of being part of the church to be called out for not having enough faith because she was depressed. And so I tried to explore that with her and help her think about other places that she could find what she needed and grieve that experience of losing her connection with that church.
Okay, thank you.
If I may jump in. Charles Bennett here is an epidemiologist with public health for quite a few years. And since retiring, I've been involved with jail ministry and also facing some issues, emerging issues among my extended family. The emerging issues, perhaps what I feel most strongly about at this moment. I have a great nephew and a grandson. Great nephew is 21. Grandson is 11 years of age. Both have been expressing concerns about what we refer to as gender dysphoria. And they've been subject, one, the older young adult grew up in California. The younger grew up in Vermont. Both of these states are known for a lot of liberality, if you will, on LGBT Q issues, but I'm concerned about what is going on and how they might be approached to understand, if you will, what it means to be created in the image of God. And how does God make us? Does God make mistakes? I'm open for advice and counsel, trying to understand that issue among others. And I will also just mention, may or may not be able to get to it, that dealing in jail ministry, I'm aware that in jails and prisons, there are many who are there, and also among homeless populations, which are growing in the United States, people who have mental disorders. As a lay person speaks to them, I'm not a psychiatrist, so I wonder how we deal with those.
Yeah, the carceral population has become a huge reservoir of mental illness, it seems, and that is a big issue. And faith-based groups have often been pretty helpful there, I know. The issue of gender dysphoria and transgender individuals is a gap in this book. We didn't really address it, but it's a very contentious and important issue. It's come up in my own family. There's a child psychiatrist in Texas who sees families with gender dysphoria, and he's collaborating with me on a proposal to the APA annual meeting in San Francisco to try to talk about it. If they accept that, then that'll be a place where we can talk some about the role of faith and how to deal with family members who are struggling with this. And I know there's been some interesting work done from a theological point of view about this, but I'm not by any means an expert in it. Maybe there's some other folks on the call who thought more about this, and especially how the church relates to transgender patients. Seeing something in the chat here.
Anyone want to respond to that particular issue?
Well, John is, can you hear me? Hello, hello?
Jenny's raised her hand.
Oh,
Yeah.
sorry.
Jenny is next, I believe.
Thank you. I'm a pediatrician and have a fellowship in developmental behavioral peds. See a lot of adolescents and with so many psych complaints, and the rise in gender dysphoria is phenomenal, and it's mostly in girls, and that doesn't fit biology at all in terms of the history of trans, which has always been male to female by and large. And, you know, I really do struggle with this because I don't think, because the psychiatric community is saying that suicides are higher in people that aren't allowed to transition and all that, but I think the data is very thin. And I've been getting lots of material from sort of a so I'm a progressive Christian is how I would describe myself, sort of a Catholic Presbyterian hybrid. But there is a lesbian community that is very anti-trans and thinks that it's a way of destroying women. And I sort of agree. We don't let 13-year-olds get tattoos. I have no idea why we let 13-year-olds take hormones that are going to make them sterile and bald and that are irreversible. And I just wish there would be more of a voice in the psychiatric community, not just in the faith community, because we just sound like we're oppressive, but in the psychiatric community to really look with some rigor at what's going on and caution. And I think Australia's done that. They're making kids go to psychiatrists. But, you know, the reasons I hear from adolescents for why they're gender dysphoric are pretty much they struggle with puberty and they struggle with peer acceptance, anxiety, depression, cutting. You know, it's sexual assault. It isn't that they grew up feeling like they were a boy. So anyway, I've talked too long, but that's the biggest issue in my work. And I really appreciate your book. It sounds fantastic.
Thank you. I know there's been some backlash on this in the UK, and I attended the last APA meeting, a workshop on gender dysphoria led by some folks who were advising caution from their experience. And they got a very intense negative response from the audience, which continued their own meeting afterwards. So it is a hotly debated issue. Maybe someone else has thoughts about it. Daniel?
John, I'm trying to figure out how to raise my hand in the virtual.
That's okay. Go ahead and ask, give
Is
your
that okay?
comment.
Yeah, so I'm Patrick Kelly. I know John from, and I know Harold from, etc. But Carl Trueman has written a book called The Rise and Triumph of the Modern Self, which begins with a question of how it is that in a matter of years our understanding of human sexuality has transitioned to the point where we can kind of, as it were, determine our own views of man becoming a woman or woman becoming a man, or any number of iterations in between, of which there are many. And the reason I would mention this book, if anyone's interested, is because Trueman does, I think he has a scholarly approach in which he gives you access to primary sources. And so it really starts from the 18th century, key figures into the 19th and the 20th century. So, I mean, if he quotes Freud, if he quotes Jung, if he quotes, he's doing extended like quotations of their primary works. And so it's not a sort of a straw man argument. I mean, if he's quoting somebody, it's going to be the best of the best. I mean, if it's, so that's that, I would just mention that, read it and then come to your own conclusions. But Carl Trueman, Trueman, The Rise and Triumph of the Modern Self, I think is at the very minimum worth working through to some degree.
Very good. Okay, I have a question, and then Daniel, actually, let Daniel go ahead and you ask your question or make a statement.
Okay, thank you. Thank you for your presentation, and Dr. Koenig. The question is, for research purposes, is there a questionnaire or some method to measure one's level of faith? And is it different for each religion?
I'm going to defer that one to Harold.
Okay, Dr. Koenig.
Sure, Daniel, yes, there is a measure, and it can be used within monotheistic religions, and it's called the Belief into Action Scale. The Belief into Action Scale, it's 10 items, and it quantitatively measures
Yes.
the strength of a person's religious faith. And there are various other, there are certainly religion-specific measures across the board for Muslims, Jews, Hindus, and Buddhists. And those measures are all available. Send me an email if there's a particular faith tradition measure that you want to look at. I have them, so don't hesitate to email me. But yeah, this quantitative measurement of faith is possible. Now, the degree to which it's accurate, can be argued, but there, at least it comes up with a number, and the number seems to be related to various health outcomes.
Can I add one more thing, Harold, on that measure?
Say what?
Can I add one more thing on that measure very quickly?
Sure.
So we're in the process of doing longitudinal work on flourishing and suffering and how it relates to belief and specifically community. And the measure that we've chosen to utilize for belief and community is Koenig's belief into action measure, which a few years ago you mentioned was one of the best pieces of research you ever put together. But very simply for people on this call, Harold describes kind of belief, measurable belief, as in two domains, as it were. How people spend their time and how people spend their money. And that seems to be fairly accurate. And so we've used that in our practice and expanding it to other practices across the country. And it's very insightful as just a primary care doctor seeing patients who, I'm in the South, though I spent a number of years in the Northeast. And so kind of spirituality means different things at different places and different people. And so this is a pretty good measure. And again, it's very short. It takes 2 to 3 minutes to fill out. I mean, I would very much recommend it to whoever's interested in utilizing it. So
Thank you, Patrick.
How do I get that?
Just send me an email.
Okay, thank you.
Yeah. harold.koenig@duke.edu.
Okay, thank you.
Absolutely. Daniel, did you have any other questions to ask?
No, that was it. Thank you.
Okay. Let me ask John a question. Issues with regard to barriers. So, and boundaries, that's the word I'm looking for. So what are some boundaries, John, that you would say the psychiatrist should be careful about when seeking to integrate a patient's religious beliefs into therapy or into their clinical practice, particularly let's say a Christian patient? What are some boundaries that you have found are important in terms of not crossing so that it doesn't somehow affect the relationship or the outcome of the therapy? Any thoughts on that regard?
Yeah, that's a big question. I think I usually think of it in terms of what's best for the patient rather than what is my own agenda. And that, of course, gets you into this whole area of what is flourishing for patients and how does our worldview inform that. So it's not quite as simple as that.
Zoom.
I think it's useful to remember the distinction that Gutile and Gabbard make between crossing a boundary and a boundary crossing and a boundary violation. You could cross a boundary by making some suggestions to a patient about churches, but a boundary violation would be something that was actually harmful to the patient. For example, by trying to encourage them to attend your own church because you think that would be better for some reasons of your own. There's a book that the Oxford published several years ago on ethical issues at the interface between psychiatry and religion that some of us on the call were part of. And the ethics committee of the APA has recently put out a statement as well on this whole area of boundaries between religion and psychiatry. I think it's being published in the Journal of Nervous and Mental Disease, which is another resource for people who are interested in going further into the nuances of what boundaries are in different clinical settings.
Great, John. That's great. And our current issue, or the October issue of Crossroads, summarizes that article in the Journal of Nervous and Mental Disease. It's a very good article, and it's got multiple different psychiatrists that have contributed to it from, I think the main group is from Yale, but from many other major institutions across the US and world as well. So thank you for that. Okay, other questions from members here of our audience? This is your opportunity to ask John questions that can help, resolve some of the many controversies that plague this field.
May I jump in once again?
Sure.
Thank you, first of all, Doctor, for your presentation. You alluded to involvement to the AA and 12 steps and Celebrate Recovery programs. I'm wondering, in my limited experience visiting some of these with family members who have had occasion to be involved with them, it seems to me that Celebrate Recovery is one which has dealt perhaps more than the others, not with sexual or pornography addictions, as opposed to pharmaceutical addictions in the more general sense, perhaps. And I'm wondering what there is to be said about dealing with churches that may have problems accepting, forgiving, whatever, achieving reconciliation with Christians who have had experience with sexual or pornography addiction.
Yeah, I think Celebrate Recovery is one place where Christians can come and feel like they're part of a Christian context and talking about this in the subgroups that they have. There are, of course, other 12-step programs that deal with this kind of issue, like Sex and Love Addicts Anonymous, that are not specifically Christian. I know that some churches take this on more than others and have a sort of accountability groups within the congregation or within a network of churches. And there's some pastors who talk about their own struggles with this from the pulpit. But generally, it seems as though it is a pretty stigmatized issue, and I think it's a challenging issue for clinicians generally, unless there's a group that has some accountability and some larger purpose. It's hard to treat sexual addictions. Maybe other folks have more experience with this than I do.
So if I understand you correctly, you are saying that having a group with accountability and if you will, also a measure of acceptance or understanding is important to
Right.
recovery.
Exactly.
But this can be very challenging to people in churches who perhaps have not experienced this in their families or whatever.
Right.
So that they do have to find that acceptance. Turn that back to the other issue that I raised earlier. I've read a little bit. Again, I'm not a psychiatrist. I came out of social science, but in epidemiology with other foci in my career. But I've read a little bit about criminality as a pathology, and again, the issues of dealing with people who have had whatever it is, psychosocial pathology leading to criminal behaviors, and yet I think there has been some success through taking fellowship and others in dealing with them, and the issues of integration back into a community if people who have been convicted and incarcerated are subsequently released back into society. Where do they find belonging and acceptance, and how do we understand their needs, not only from a clinical perspective, but from a broader culture as well?
I'm sorry, I didn't catch all of the end of that.
How do we understand their needs from a not just in the psychiatry setting, but also back into a community of faith.
Yeah, I know that the sociologists Farron Johnson and Sun Jung Moon at Baylor have done a lot of work on the role of faith in prison populations. And you might want to look at some of their work.
Thank you.
This reminds me that we didn't really discuss the issue of personality disorders in this book, which I think probably is a gap, and one that you know, is relevant if you think of personality disorders as deficits in virtue, which Robert Cloninger would argue. There's a lot of room to think about the spiritual dimensions of personality disorders and their treatment, and the ways that faith communities can foster virtue.
John, if you could recommend one or two books on personality disorders, what would you recommend? Is it Cloninger or?
That's a good question. I think he's done some of the best research in personality disorders and personality development. So yeah, I'd probably start there. In terms of treating them clinically, it would probably depend on the personality disorder.
What was that name again? Who was the?
Robert Cloninger. He's a psychiatrist at St. Louis.
Ann Bauer has a question. Ann, go ahead.
Hi, thank you. Thank you again for your presentation. I'm coming from a perspective of being a psychiatrist and a chaplain. It sounds to me, you know, I must say, I don't know that much about faith-based treatment, but what a little I've read about it, it seems mostly like it's an outpatient on an outpatient. So, and I've noted that, I noted that McLean's has developed a spirituality-based inpatient program. So I'm curious if you, from your knowledge about this area, do you see this treatment as primarily a long-term outpatient type of an intervention as opposed, and do you have any comments about its use in more of an acute psychiatric setting?
Yeah, that's a great question. I don't have direct experience with it. I know that Tom Okamoto, who wrote co-wrote one of the chapters about integrated treatment, describes the chain of inpatient and partial programs that existed for a while anyway in the California area. I think most of them are no longer there. There is an integrated inpatient residential program in Florida that Carl Benzio has. David Rosemarin is the psychologist at McLean who has worked on their spirituality consult service, and also has gotten a chaplain there in the last few years. And he's published some on spiritually integrated therapy in partial hospital patients. Not so much Christian or Jewish, it's more generically spiritually informed, but it's for the partial hospital population.
And if anybody, and if you need the email for David Rosemarin or for the fella there in Florida, just send me an email. I'll get it for you.
Thank you very much.
Okay, Charles, go ahead. Go ahead and unmute yourself.
Thank you. As I said, I do have this background in public health epidemiology, and I know that some of the research at Duke University, at least, that Harold has undertaken and others with him, to understand mechanisms of healing, if you will, or what goes on physiologically as other processes are present. I guess I'm interested, what investigations, if any, have you done about the underlying antecedent factors that may be affecting things such as this rise in gender dysphoria or other phenomena that are observed? Are there factors in our society, factors in education, factors in what is taught and not taught in science about how the world came to be the incredible place it is, but so much effort to, if you will, remove God thinking from all of that, and how does that affect our own the self-understanding of people who may be experiencing the conditions that are of concern to this group?
Yeah, I think I may defer that one to Harold again too, as the person who's reviewed all the research recently in this area for the handbook. Harold, do you have thoughts about that?
You know, there's not that much physiological research looking at, you know, the some of the issues that we've been talking about. Not much at all. Particularly in terms of brain scans and, you know, functional MRI scans, et cetera, to see whether there are changes in the brain. And, you know, a lot about this area we just don't know much about, particularly with regard to some of the adverse childhood experiences that occur, and whether or not those adverse childhood experiences actually cause changes in the brain that are permanent versus reversible. All of this is, you know, is cutting edge right now, and we just don't know the answer to those questions yet. So a lot to be done in this area, but not much systematic research with regard to these issues. So good question, Charles. Maybe this will stimulate some research.
Well, it seems to me, again, from the public health standpoint, that we are certainly interested in understanding and treatment, but we are also interested in understanding that might lead to prevention.
Yeah.
To increased health from the get-go.
Absolutely.
In terms of some of the larger social and public health aspects of this, you might be interested in Tyler Vanderweel's program on human flourishing at Harvard, where he's funded now to do a pretty extensive global study of what constitutes human flourishing, what contributes to it. Again, more on the prevention and public health side of things.
Thank you.
Yeah, and we have a chapter in our third edition of the handbook that really is focused on public health recommendations in terms of, you know, public policy, et cetera. So towards the one of the last chapters focuses on that topic. So that'll be of usefulness to you all when that book comes out.
Great.
Now, Leland Jones, did you have a question?
Yes, I have a question and comment. I always wanted to meet you, Harold, and heard a lot about you, and I'm glad that John, I really appreciate you, and I'd like to get your book. I'm a psychiatrist. I was a family physician. I'm a minister also. So my comment and my question is about inner healing and deliverance. And I've had very good results with inner healing, especially with PTSD and traumas of all kinds. We mentioned personality disorders, and when you really go back far enough, you really find a lot of trauma in these people. And so I've got very good results with Theophostic, with Dr. Ed Smith, and with Elijah House and HeartSync, and several other, even psychiatrists. And so I just wonder, is that something that you have researched, have looked into, or published? Inner healing and deliverance.
Yeah, I've certainly anecdotally heard people who benefited from those kinds of approaches. I don't know about the research in this area, Harold, do you know?
Yeah, nothing with regard to the Theophostic practices, and those really, I agree totally, that those have tremendous potential, particularly in Christian psychiatry. But you know, we did have, in terms of deliverance, I'm not sure what you mean by deliverance, Leland. Are you talking about exorcism, or what are you talking about there?
I guess some people would call it exorcism. I tend to come from the background where you're using more inner healing, and then the inner healing can flow into deliverance. So it's not so much deliverance per se. It's like the strong man and the stronghold. The strong man is the name of the spirit, but the stronghold is what has allowed him to give him strength, lies, beliefs. So Jesus said you first have to bind the strong man. The strong man is the name of a spirit, and there are many different names of spirits. But I just mentioned, you meant sexual addiction. I've had very good results with sexual addiction. It's not I actually had a group on sexual addicts. I had a group on multiple personalities, and found very good results with inner healing and deliverance. So I'm more on the inner healing that leads to deliverance. However, I do work with people that are on the other side. So yeah, I think it's been phenomenal. And as a psychiatrist, I don't do that with everybody, but I make it available. And so when I first found out about Theophostic, I went to a conference up in Canada, where I'm from Buffalo, was from Buffalo. Anyway, and we went up, I couldn't believe it, but these counselors were saying that one session sometimes with PTSD. Wow. And I heard Ed Smith speaking in Ontario. I couldn't wait to get back to the hospital, Buffalo General. I said, I hope I have somebody in the house with PTSD, and I was away for the weekend. And I had one patient. I just learned about this. Now, I had used the Elijah House prayer counseling course for 7 years. I was a director at our church, which is a type of inner healing, but you're more praying about the trauma as opposed to inviting Jesus into the trauma. Okay, that's what the inner healing I'm talking about. You're actually inviting Jesus to go back into the traumatic memory. And I couldn't wait to get back to the hospital. And certainly it took me about an hour for this woman's trauma. But after that, she's like, I'm ready to go home.
Wow.
I do not have the fear. I can actually go there into the traumatic memory. Jesus is there. I feel the peace and I feel the presence, and I'm not terrified anymore. And I wasn't ready to discharge her. I'm like, I don't know if this is going to last. But sure enough, this was my first patient using Theophostic. Like I said, I'd used these other approaches. Now that was close to 10 years ago. Okay, so we've used it in so many other ways that I just am so impressed with this.
Yeah, no research on this area, but potential, tremendous potential, to do randomized controlled trials to look at the benefits of what might be so important for so many people. It's just a matter of funding support, getting the money to do it. But my gosh, I hope that Leland, you don't mind if some people email you about this. I mean, it sounds fantastic.
Yeah, Dr. Leland Jones at gmail.com. I see Dr. Donna Potter here. I know she's got her hand up. She is very expert in many of these areas.
Donna,
yes,
go ahead.
Thank you so very much for this forum opportunity. And Leland, yes, it is always great to be in your presence as well. Leland and I have traveled in some of the same groups, and I have some of the same experiences that Leland has had. I am into inner healing as well, and also use the heart sync therapy, which Leland and I had gone to Canada to pick up as well. And I do that quite often. I have been a counselor in recovery services for 22 years now. My youngest client is, 3 years old, and the oldest is 97. So I have a gambit of all kinds of opportunities to experience inner healing and how it applies to faith. And I get many, non-Christians in as well. Everything I do is by referral. I don't have to market a single open opportunity. So I thank you each because you're helping me to continue to grow as well. I am not a psychiatrist. That's why I used to rely on Leland all the time. I am a PhD in Christian counseling, but this is absolutely phenomenal. So I just thank you from the bottom of my heart, guys.
Thank you, Donna. Okay. Any other questions here? May we have room for maybe one question and then we're going to have to conclude. Going once? Going twice? Okay, Daniel's got his hand up. Daniel, one more question.
Okay, during the COVID-19 pandemic now, we were offered vaccinations, but many Christians or whatever religion said, God will protect me. But then they became sick with COVID. How do you approach that person?
That's a tough one. I haven't had to do that, but I think you would have to be caring and diplomatic, and it'd be a process of compassion and trying to help them deal with the consequences. Yeah.
Yeah. Those are good words, John. Compassion, kindness, and care. A lot of listening as the person ventilates. Okay, well, we're at the end, John. Thank you so much for a tremendous presentation, and for all of you for some great questions in a wonderful discussion. So we'll see you next month. Take care and God bless.
Thank you very